both influencing each other in multiple ways. The current session will highlight and address different aspects and issues pertaining to this interface. Today, I am very pleased to have two distinguished faculties from diabetes and psychiatric segment. First is Dr. Suhas Gopal Erande, sir, and Dr. Rajeev Banhatti. Dr. Erande sir has done his MD in medicine from Sassoon General Hospital, Pune in 1985. He is also ICMR Research Fellow in Diabetes. He is practicing as a consultant from last 33 years, and he has written many book chapters and academic articles for physicians at national and international level. He has been involved in phase 2 and 3 clinical trials in diabetes like AGE International Study, Landmark National Study ongoing. He has also basal insulin. He has also been part of basal insulin guidelines in international journal. While Dr. Rajeev Banhatti is MD in psychiatric segment, and he is also experienced consultant with about 15 years of experience of leading teams and services in delivering assessment and management in psychiatric illnesses. He is a visiting lecturer for MSc in Child Mental Health course. He has been editor in newsletters of AIMH, that is Association of Infant Mental Health. We'll start the session. Sir, it is over to you. Dr. Erande, sir.
Thank you, Manisha, for the kind introduction. Welcome all my friends who have joined in for today's academic session.
Yes, sir. Your screen is coming. Okay, perfect.
I will be trying to talk on the organic or the body side of the story of diabetes and chronic ailments. And Dr. Rajeev will, of course, be delving into the psychological and psychiatric aspects of the same. So that's the reason why I have labeled this as Do Mind the Mind in Diabetes. There have been some, you can say, very important key changes in the thought process of the medical fraternity. And there is a reinforcement of the increased prevalence of diabetes with an expanding range of psychiatric disorders, including major depressive disorders or MDD, bipolar and related disorders, schizophrenia spectrum, and other psychotic disorders, anxiety, sleep disorders, feeding and eating disorders, stress and trauma related disorders, and regular screening of metabolic parameters in individuals taking psychiatric medications, particularly but not limited to the atypical antipsychotics. So this is a way of looking at the scene from both the diabetes side of the story and from the psychiatric element side of the story. Why we have kept this program? It is very important to appreciate the philosophy behind this. In Western medicine, we are very good at treating the disease, less good at treating for this statement. Just like the systemic processes like hypertension, diabetes, negative psychological states, dysphoria can also damage the patient's health. One of the important examples is what is called as the Takotsubo stress-induced cardiomyopathy, a gross example of altered mind status directly reflecting into worse physical health. Another example here is the Northridge earthquake, US, which happened in 1994, and that resulted in 260% increase in cardiovascular deaths compared to the other days of the year. So this is something which is very illustrious example that mind perturbations can certainly result into bad health and even mortality. What about COVID-19 pandemic is another open question, which probably time will actually solve. What is actually meant by stress? Consequence of failure of an organism to respond appropriately to emotional or physical threats, whether real or imaginary, is defined as stress. Stress response is cognitive, behavioral, emotional, or physical level that can have serious negative impact on the body if activated in the long term. So diabetes and mental illnesses are intertwined with each other very intensely. What are the brain changes which happen in diabetes? Structural, functional, and neurochemical changes in brain regions which are responsible for the affect and cognition may have increased the risk of depression in both type 1 as well as type 2 diabetes. Animal models have shown that hyperglycemia negatively affects the hippocampal integrity and neurogenesis, reducing neuroplasticity and contributing to the mood symptoms. Human studies in people with diabetes have shown hippocampal atrophy, which could pose difficulties in learning, memory, emotional expression as well. Diabetes and psychological issues are, as I told you, are intricately woven with each other. Diabetes is a chronic metabolic disorder which affects physical, mental, emotional, and social health of the patients. We are all aware of that. These psychological problems adversely affect the patient's metabolic outcomes and social well-being. The emotional, psychosocial, cognitive, and behavioral problems, if addressed, can improve the diabetes self-care, diet, exercise, regularity of the medicines, adherence to the treatment plans which we explain and give to the patients, and health-related quality of life, which is ultimately the goal of good treatment on the part of the healthcare professionals. The Dawn study, diabetes, attitudes, wishes, and that can result into reduced quality of life for diabetic patients. What are the bridges which actually join the psychology, psychiatry, and diabetes? Many patients cannot just digest the idea of lifetime need to take anti-diabetic drugs, and this itself can result in poor compliance to treatment and diabetes self-management. These are the bridges between poor control, poor self-management, reduced quality of life, complications, reduced productivity, limitations of mobility, and increased cost of treatment. Emotional or psychological needs of diabetic patients are sidelined mostly, and the gap keeps on widening with diabetes duration, onset of diabetes complication, despite the patient's personal efforts and to some extent maybe the healthcare professionals' individual efforts. What are the efforts to seal the gaps? Some organizations like the SIGN, Scottish Intercollegiate Guidelines Network, National Institute of Health and Clinical Excellence, the NICE, Institute for Clinical Symptoms Improvement, have certainly tried to incorporate psychological and emotional needs of people with diabetes into their evidence-based guidelines. Diabetes Canada has published their position on mental health in diabetes in 2018 very elaborately. We will look at, you can say, the correct, you can say, propriety, or this is the central slide of this whole program. One is the level of the problem, the first column. The second column is the role of diabetologist, that is me. And the third column is the role of the mental health professional, that is Dr. Rajeev. So if the level of the problem is general or level difficulties, then what I have to do? Ask and screen for presence of such difficulties. I should inquire and document these things. I should identify the difficulties being faced by the patient, and I should try offer simple advice and counseling on how to handle these difficulties. For example, difficulties in the discipline of the diabetes diet, or maybe physical exercise, and if the patient is facing difficulties in performing that exercise, regular medication and the exact time to take the medication, the correct timing of the medication, these could pose difficulties and I should solve them. And I should engage the caregivers in process of delivery of health, that is the family members of the patients or the parents of a type 1 diabetic. What is the role of the mental health professional here? Help the diabetologist acquire skills to identify and solve such difficulties. Then the next level of the problem, intermediate level difficulties. I should ask and screen for presence of such difficulties, identify the difficulties being faced, consult the mental health professional on approach to handle the difficulties, and offer counseling to solve these difficulties in tandem with the mental health professional. The mental health professional, of course, can offer support to us, that is diabetologists, to address these difficulties and offer direct intervention with the person with diabetes for solving these difficulties. If the level of the problem, the mind problems or psychological problems or psychiatric problems is complex or severe, then I should ask and screen for presence of such difficulties and identify the difficulties and refer the patient to the mental health professional, who will naturally take over as far as the psychiatric problems are concerned. What are the levels of psychological problems in diabetes? Elaborately, level 1 is the general difficulties in coping with diabetes and its consequences. Level 2 is significant anxiety, lowered mood causing difficulties in diabetes self-management. Level 3 calls in the mental health professional for diagnosis and treatment of depression, anxiety, or obsessive compulsive disorders. Level 4 is more severe problems which need biological, psychological consultations and treatment. And level 5 is more complex issues which need psychiatrist interventions. This diagram is again something which is a very important slide in my presentation. This shows the interplay between diabetes, major depressive disorders, the MDD, and other psychiatric conditions. I will not read out the whole slide because it would be a bit, you can say, cumbersome. But let us keep in mind that unless the mental status of the patient is normal or unless the mind is healthy, the person will find it certainly very difficult to not only cope with the diagnosis of diabetes, which is usually a lifetime kind of a disorder, the dietary discipline, the physical exercise which the patient is supposed to put in, at least 200 minutes of, let's say, aerobic exercise per week, the American Diabetic Association recommendation, or maybe the taking of medications on regular time, maybe before meal, between meals, after meals, etc. Regular self-monitoring, regular or periodic visits to the diabetologist for assessment of the progress, yearly or maybe 6-monthly checkup of HbA1c or the retina or the cardiogram or the foot checkup, kidney checkup, so on and so forth. So the patient can simply get bogged down because of the demands of the diabetic world. And for this, the mind has to be really healthy. If it is not, then the patients can certainly have, from the psychology side, can have anxiety, stress, other psychiatric disorders, which can alter his feeding, his eating behavior, his sleep-wake cycle, and all this, and the adverse compliance to the medication certainly complicate the metabolic control, and onset of complications, the vascular complications, neurological complications can certainly be there waiting in the wings. From the psychiatrist side, if the patient originally is somebody who is prone to develop anxiety, depression, and all those things, then these kind of people are less likely to really do a good physical exercise. Some of the, you can say, these bad physical lifestyles can make them stick or adopt to maybe excess smoking or excess alcohol, which can alter their health. And if they get diabetes, then naturally the situation can actually worsen even to the further extents. So this is broadly the interplay between diabetes on the physical side, the mental side of the depressive and other psychiatric conditions. So mental illnesses increase the risk of diabetes and diabetes complications. So this is one part of the story. Vice versa, diabetes can make the person anxious, stressed, and maybe even depressed. Non-adherence to medication and self-care, functional impairment, risk of complications, healthcare costs, and risk of early mortality are the issues which actually stand as something which is a common boundary between mental illness and type 2 diabetes. Major depressive disorder increases the risk of type 2 diabetes by as high as 60%. So the cause and effect phenomenon is actually two-way as far as the mental illnesses and type 2 diabetes is concerned. Depressive symptoms are present in at least 30% of people with diabetes. Major depressive disorders, also called clinical depression, occurs in 10% of people with type 2 diabetes, which is double the rate compared to the non-diabetic or general population. Comorbid depression worsens the clinical outcomes in type 2 diabetes. Possible explanations are lower levels of physical fitness, and medication adherence could be a bit lesser with comorbid depression in diabetic patients. The 30% figure can certainly vary. I will show you one of our publications down the line. So this is the downward cycle of depression and diabetes. If we start with the top of the diagram, which is depression, then that can certainly make the person lack motivation for living or for maybe discipline in the life, which can result in poor management of diabetes. Diabetes poor management can result into hyperglycemia, which itself can actually cause a feeling of fatigue and lethargy. The coherent thinking also can get altered because of hyperglycemia and sustained hyperglycemia, which can worsen the mood of the patient. And this again puts fire to the ongoing depression. So it becomes a vicious cycle of depression and diabetes. This is a very, you can say, interesting slide which tries to search for common origins for both depression as well as type 2 diabetes. You can see here that we know that there are fetal origins of adult disease, and fetal nutrition, malnutrition in the in utero status can certainly make the baby uh, underweight or small for gestational age. But when this baby gets birth and when baby gradually starts growing in age because of the plenties of food which is there now, then the patient's metabolic status or that baby's metabolic status, which is actually designed for the low body mass index, when the person starts eating more, then the body mass index goes up and the metabolic system gets decompensated. So the fetal malnutrition and small for gestational age babies in adulthood can become diabetics. Depression is common in type 2 diabetes. Depression is associated with increased mortality, and treating depression alone does not improve the glycemic control. You need to actually attack both the physical side as well as the psychological side of the story. The fetal nutrition itself can actually result into what is called the innate inflammation. The genomics and the social adversity certainly put, you can say, fire to this ongoing innate inflammation, and the innate inflammation itself, according to some research reports, can result into both type 2 diabetes and depression. So these are the common origins of both depression and diabetes. Depression worsens the diabetes mortality. This is a very illustrious publication from Diabetes Research and Clinical Practice 2005. If the person has no diabetes, no depression, then the hazard ratios of mortality is, let's say, taken as 1, which is the index. If the person has no diabetes, has only depression, then the hazard ratio of mortality goes up to around 1.5. If the patient has diabetes, no depression, then this hazard ratio goes to around 2. And if the patient has both diabetes and depression, naturally the hazard ratio shoot up to practically 3.5. So this actually shows that both diabetes and depression actually do not add, but they multiply each other as far as the hazard ratios for mortality are concerned. This slide actually shows us the bidirectional link between depression and diabetes. These are many prospective studies of depression and diabetes. Baseline prediction of type 2 diabetes when the patient has incident or the people have incident depression, and exactly vice versa. When diabetes is incident, what is the baseline predicting depression? So as I already have told that these two, depression and diabetes, or mental ill health and diabetes, are cause and effect both ways. So there is another interesting entity these days discussed, which is called as diabetes distress. What is the peculiar entity or definition of diabetes distress? Despondency and emotional turmoil specifically related to caring for diabetes, the need for monitoring and treatment, preoccupation with complications, and the effects on various relationships related to poorer diabetics outcomes. So this is what is the diabetes distress, defined by a group of researchers from Australia. Diabetes distress, this is the National Diabetes Service Scheme, Australia. There are effects on the patients, there are effects on the other, you can say, people or other stakeholders also. So the patients feel overwhelmed with the demands of diabetes self-management. They feel angry, frustrated, their mood is low, and they can feel burnt out, posing difficulties in self-care behavior and metabolic control. The family and friends of the diabetic person, this applies more to the type 1 diabetes. Family and friends find it difficult to understand the psychological needs of the diabetic patient, making communication difficult sometimes. The food restrictions for the diabetic patients can pose a peculiar challenge for the lady of the house, and this can prove to be a friction point amongst the family members, and the family might find it tough to change and adjust for the person with diabetes. there are more repercussions. The physicians like me also can become preoccupied with HbA1c, also called as glucose-centric physicians. So we can become glucose-centric or A1C centric, and we also can have a fear of complications which can take onset in the patient. And if the patient is not maintaining a good glycemic control, the physicians are afraid that the patient might develop complications. And this might reflect in the patient's diabetes self-management. The possibility of putting blame on the patient by such glucocentric physicians or anxious physicians may be higher. And this can actually spoil the patient-doctor relation also down the line. Parents of type 1 diabetes patients, their psyche is a special issue in itself. We will have to probably devote and request Dr. Rajeev to actually pitch into this, because Dr. Rajeev specifically takes interest and has been working in the UK over last more than 2.5 decades for child psychiatry. So we'll request him to pitch into a specified program for type 1 diabetes, their parents, and psychological challenges. Suffice to say right now that the parents may be victims of guilt. They may feel that it is because of them that their child has developed type 1 diabetes. These parents can become anxious, depressed, obsessive compulsive, and this itself can pose a barrier to the type 1 diabetic patient's well-being and management. Diabetes distress versus major depressive disorder. Brief comparison. For diabetes distress, we have what is called as a diabetes distress scale, which is a 17-item questionnaire, vis-a-vis major depressive disorder MDD, which can be assessed by patient health questionnaire for depression, which is called as PHQ-9. There are 9 items in that. The format for diabetes distress is self-report using rating score from 1 to 6 based on feelings and experiences over the past week. For MDD, self-report using ratings from 0 to 3 based on the feelings and experience over the past 2 weeks. And then the domains are emotional burden subscale, 5 items, physician-related distress, regimen-related distress subscale, diabetes-related interpersonal distress subscale, etc. So this is something which is a detail if you really want to measure the diabetic distress or the major depressive disorder. Screening for depression or anxiety symptoms is important in patients with diabetes. I should not be too much, you can say, leaning on the fasting PP sugar, the blood pressures, cholesterol, HbA1cs, etc. But I should also inquire about the psychological health of the diabetic patients. So the purpose is diabetes specific. I should actually undertake what is called as a paid scale, which is problem areas in diabetes scale, or the diabetes distress scale, DDS. I should inquire the quality of life, and there is again a screening tool called at WHO5. For screening for depression and anxiety, we have hospital anxiety and depression scale or HADS, patient health questionnaire PHQ-9, which we have already alluded to, and there is a big depression inventory BDI, which can be downloaded easily on a smartphone. Beliefs underlying psychological insulin resistance. I am just taking insulin resistance, psychological insulin resistance as an example, because this is very, very common and very intimidating for the patient to accept insulin and for a better control. So the patient has a perception of worsening illness severity if we discuss addition of insulin to the ongoing regimen. Requirement for insulin for the patient represents a personal failure to self-manage the illness. The need for insulin is perceived as losing control over diabetes, and there is an apprehension on the part of the patient that there could be now, the future could be painful, uncomfortable, and injection certainly can be, you can say, a threat for the patient. Lack of personal benefit for the added stress and effort of using insulin. So this can, you can say, culminate into the patient's rejection of accepting the insulin injections, which we commonly see in our day-to-day practice. These are the cognitive behavior therapies for managing the fear of hypoglycemia. This is a bit detailed, and I will spare, you can say, all this for the psychiatrists to discuss. So this is a, you can say, slide which tries to again take our attention to the interface, what are the psychological factors in diabetes. So emotional distress in diabetes, the psychological reaction on the part of the patients. This is the emotional or crisis reaction, especially at the time of diagnosis or at the time of hospitalization. The patient can actually have a psychological shock. The patient can deny the diagnosis of diabetes or complications. The patient can become angry. He can feel guilty or he can feel anxious. Diabetes distress the patient can get overwhelmed because of self-management, can get frustrated, he can find difficulty in communication with the family members, friends, with the spouse, or even with the diabetologist. And there can be distress on differential food in the family, as we have already discussed that. Phobia reactions. There could be fear, especially of starting on insulin or maybe other injectables. There could be a phobia of needles. Hypoglycemia is certain one thing which the patients are really, really afraid of. They are, of course, very much afraid of complications, heart, brain, or maybe amputations, kidney and eye complications. And the patients can actually contract obsessive compulsive behaviors. And then there could be psychiatric disorders like depression, anxiety, delirium, eating disorders, bulimia or anorexia nervosa, especially in type 1 girls. And some patients can, of course, go for schizophrenia. So poor glycemic control, poor self-care behavior and treatment adherence, and thereby reduced quality of life can actually fuel what is called as a vicious cycle between the psychological issues and diabetes. So diabetes affecting the mental health, rapid mood changes, mental fatigue, lack of clarity of thoughts, and anxiety, depression, diabetes rage or aggressive behavior, especially with children, memory loss with the elderly diabetics, sadness, anger for all diabetics, self-regulation or discipline, willpower and resilience or coping gets compromised. Diabetes and psyche interface, the patient factors, the patient, his patient's lifestyle choices are limited. Illness factor, both depression or diabetes can set in what is called as a pro-inflammatory state. Medication factors, a lot of antipsychotics can set in what is called as insulin resistance and central obesity. There could be psychiatric medications like amitriptyline, olanzapine, quetiapine, or risperidone, which in their own right can make the patient obese or maybe centrally obese, and they can incite, you can say, new onset diabetes or maybe drug-induced weight gain. And this can make, you can say, a lot of complications as far as the management is concerned. The treatment options again are something which will actually be left to Dr. Rajeev for detailed discussion. So these are the people taking high risk psychiatric medications who need a regular metabolic screening at a periodic time. This is recommended by the Diabetes Canada. And to end actually my presentation, look at some of the important pictorial presentations. Exercise is something which can be a very good solution to relieve the psychological issues for a diabetic patient. So on the day of diagnosis, decide to do a good physical exercise. That's what I actually insist on, because good physical exercise by the pheromones, which can be secreted by aggressive physical exercise, that can certainly, you can say, improve the mood of the patient and the positive thinking of the patient. These are examples of famous people who are diabetic, but who are still actually very famous and very successful in their careers. The patient should not become very obsessive. They shouldn't be too hard as far as the discipline of diabetes, diet, exercise is concerned. They should actually be more balanced in their attitudes. And Diabetes UK, this specifically I have brought in for Dr. Rajeev is from UK. So these are the 15 points. The last point, the 15th point, is the emotional and psychological support which diabetic patients need. And I should remember that. So that's very important. Ending my presentation with a very important slide called as a Munchausen syndrome. This is a mental disorder in which a person repeatedly and deliberately acts as if there is a physical or mental illness, when actually he or she is not really sick. A lot of type 1 diabetic patients may use their diabetic status to exploit the parents, teachers, siblings, or peers, making their control brittle by omission of insulin, inadvertently to lose weight, and this results into hospitalization for diabetic ketoacidosis, or the same children could go for overeating and severe hyperglycemia. Poor financial or educational status could be a good cause of such situation. However, it is important to keep in mind that these could be probably more important. The educational status, financial status could be more important than the archaic sense of Freudian female hysteria. So don't say that type 1 girls are only actually behaving like way. There are, you can say, more varieties of patients who can actually have that kind of a behavior. So my friends, I end my presentation here and I look forward to the further presentation on the psychiatric or mind aspects of diabetes story by Dr. Rajeev Banhatti. Thank you so much for your kind attention.
Thank you.
Yes, sir. Your screen is coming, sir. Okay, perfect.
Hello. Can
Yes, sir.
can everyone hear me?
Yes,
Sir,
sir.
you are
Yes.
perfectly audible and visible.
Yes, Raju, we can hear you.
And you can see the slide as well?
Yes,
Yes,
yes.
sir.
Okay.
We can see the slides.
Okay, right. Thank you. Thank you very much, Dr. Suhas, for that excellent presentation. And even though we were together in the medical college and are very close, I'm really impressed to learn about your new book and also the work that you have done in diabetes. I cannot claim to have expertise in diabetes at all, but for my sins, I have been a psychiatrist for many years. In '85, I got my MD, and then I got the UK fellowship as well. And I've been working in UK for probably 25 years now. And nowadays, mostly as a child adolescent psychiatrist, but for many years, I have also treated adults. So I have some experience of diabetes and psychiatric problems. I was struck by the examples of the high achieving people that Dr. Suhas showed at the end. And I remembered one big example. I'm a big fan of the fast bowler Wasim Akram. And I understand Wasim Akram has a diabetes type 1, and he has managed to uh, achieve things as a cricketer as well as an excellent commentator in spite of all the precautions and discipline that he has to maintain for his diabetes. So I really respect him highly. Looking at the links between diabetes and psychiatry, they can just occur independently. So there may not be any direct connection. For example, someone like Wasim Akram can have just the diabetes, but extremely good discipline. So that's absolutely fine. But then sometimes, as we know, depression is a very common disorder. 1 in 10 people usually go through some sort of depression in their lifetime. Nowadays, it's becoming 1 in every 3 can have some experience as well in some of the recent findings. And so it can occur as independent um, condition at different phases or stages in life. But one thing is very true, that having diabetes is a big risk factor for development of psychiatric disorders, many psychiatric disorders. They can be as mild as a generalized anxiety, but also can have social or phobic anxiety because of the restrictions that the food and other issues that the person with diabetes has to think about. Someone having a psychiatric disorder is certainly at the risk of emergence of diabetes for various reasons, as we can see later on. And the lifestyle changes, the lack of motivation for exercise, as well as the medication and the interaction of medications can lead to diabetes. Having treatment for depression, anxiety, or even psychosis certainly puts someone at a risk for treatment adherence for both for psychiatric drugs as well as the diabetic medication or the dietary discipline. If someone has both diabetes and psychiatric conditions, certainly the quality of life is very often impaired. even in the best case scenarios, one thing is that the cost of care, of course, is twofold. Means in the UK, we have been really blessed to have a national health service. So the cost is one thing that people do not stress too much about. But for most of the people everywhere, increased cost is a real hindrance and a real limiter in terms of what you're able to afford to treat the conditions. And like Dr. Suhas showed, this may not be just the addition, but sometimes it multiplies if you have two conditions. And obviously, for those practical reasons, one can have a very poor treatment adherence, leading to elevated HbA1c levels, which indicates poor glycemic control, and obviously increased emergency room visits due to diabetes ketoacidosis or other crisis related to diabetic crisis. Now, this slide just shows basically quite a significant difference in terms of how the depressed and non-depressed adults with diabetes behave in terms of their glycemic control, and the very big swings, ups and downs in the orange color are for the depressed population, and relatively reasonably softer curves are the green non-depressed people, for obvious reason that we have covered a few times already in the previous and this presentation. Depression has a direct effect on blood sugar control. And glycemic control, or the glucose that's available, that has a direct effect on cognition. We looked at the general effect on psychiatric condition and depression, but specifically cognition, which is another thought for another name for thinking and logical thinking, using memory, logic, abstract processes in terms of thought processes, that is cognition. This is affected very badly if the glycemic control is poor. Now, this study, Accord Mind trial, shows quite a huge sample, 2,977 patients aged 55 to 80. The mean age was 62 years with type 2 diabetes, treated with standard care or intensive glycemic control. And in short, the intensive glycemic control was certainly related to a more preserved cognition, less impact on cognitive control. So 20% of patients found to have undetected cognitive impairment at baseline, no difference in any of the cognitive tests at 40 months, and greater mean total brain volume, which has a correlation with cognition. That's in the people with intensive control. So standard care can be improved, and one should aim for a much better intensive control of diabetes. What time you are able to detect cognitive dysfunction and catching it early can have a very beneficial effect on the future course of the cognitive dysfunction and progression of dementia as well as progression of diabetes. So the early detection can help in maximizing function. Early treatment also can be started, which improves the health-related quality of life, preserves the independence for a bit longer, and better clinical management reduces the healthcare costs, and certainly the amount of crisis, amount of burden that the near and dear ones, the carers, experience. So if the physician is aware of the need for screening for psychiatric disorders, it's extremely useful, it's very important. And in the modern age, it's becoming as a default position that should be the case in every case that you treat. Up to 45% of cases of mental disorder and severe psychological distress go undetected among patients being treated for diabetes due to patient and physician related factors. So PHQ 9 is a very simple questionnaire. Symptom checklist 90 is a bit longer. HADS is a hospital anxiety and depression scale. Is a fairly simple, small questionnaire, just 1 page. And these are all available online. Actually, Dr. Suhas had a link for some of the questionnaires that he showed. They can be given, or another questionnaire which is called GAD, General Anxiety Disorder Questionnaire. It has only 7 items. It's not here, but that is, if one Googles GAD, General Anxiety Disorder Questionnaire, 7 items, that gives a quantitative idea of how, whether the person has mild anxiety, moderate anxiety, or severe anxiety. Big depression inventory or other depression scales, they give a very good idea of whether the patient is depressed and whether the patient is suicidal. So routine evaluation for pain, anxiety, and depression is, I think it should be unavoidable. It should be done for every case. And that can be taken into account when the treatment is being planned. The reason we'll see later why, how, in what sort of ways diabetes is depressogenic. So how does it lead to anxiety and depression a bit later on. Before that, diagnosing diabetes in patients suffering from psychiatric illness. Let's see the reason, this is actually more applicable to psychiatrists because anyone with any serious mental illness like major depressive disorder, bipolar affective disorder, or schizophrenia, any psychosis will have increased risk of diabetes because of the impact on their lifestyle, propensity to go to be smoking and not exercising, as well as eating a lot of comfort food, fast food, and neglecting healthy part of the diet like vegetables and fruit. Also alcohol, and this all I'm talking about is predating the use of even antipsychotics. But after the antipsychotics are used, they all increase the risk of poor glycemic control. They increase the blood sugar as well as lipid. They increase lipids. They also disturb the liver function, liver enzyme balance. And the list is given here. The old phenothiazines we hardly ever use in psychiatry now, but the ones that we use, olanzapine, risperidone, quetiapine, they all can cause problems. Clozapine, which is used only with special blood monitoring in the Western countries, but which is used more freely in India. And in India, the patients are for some reason less prone to get the granulocytosis, the more serious side effect of clozapine. So the blood monitoring is not as rigorous as it is in a country like UK, but they can have a big impact on the insulin resistance. They can induce insulin resistance, and they can increase the blood sugar. So they can be diabetogenic. And this slide shows the relative risk, the pooled relative risk from many studies. And it was 1.26 and 1.37 using the random effect model. So basically, if you look at the two lines on the right of the line going through one, those are the risk factor, and the relative risk is 1.37 to 1.26 for onset of type 2 diabetes. A diagnosis of diabetes in patients with dementia, again, this will be seen more on the psychiatric side. One needs to reconsider the aims of care, and the cardiovascular risk assessment will be more rigorous, and hypoglycemic risk will have to be taken into account while you are planning for any, in addition to the care required for dementia, as well as the medication to arrest or delay the dementic process. And this is a big slide, basically showing so many potential mediators of cognitive impairment with type 2 diabetes mellitus. So in diabetes mellitus type 2, cognitive impairment can be through various mechanisms: the genetic predisposition, cerebral microvascular disease, dyslipidemia, hypothalamus pituitary axis dysregulation, acute hyperglycemia. Every attack can lead to the death of a few gray cells, few neuronal cells, advanced glycation end products, a bit of a toxic products which can be stagnated in the blood. Then depression, inflammatory mediators. Depression can lead to pseudo-dementia, but it can also worsen dementia. Inflammatory mediations, recurrent hypoglycemia, drug therapy, hyperinsulinemia, and some of the drug therapy direct, unfortunately, can be toxic side effects. Amyloid deposition, like the other toxins we mentioned, and hypertension causing microinfarcts, rheological factors, so serum factors, and macrovascular disease. All these potentially the same common, they will lead to the common outcome of cognitive impairment. And this is the same thing shown in a different way in this slide, which is the mechanism that link diabetes in the middle, if you see, and dementia. So on the one side, comorbidity, medication, and other side, genetic predisposition can add to diabetes, which can be associated with hypertension, obesity, dyslipidemia, and like we saw already, all those mediators in all the squares can lead to brain pathology, vascular pathology, or Alzheimer type pathology, or mixed pathology. So a mixture of Alzheimer's type dementia, or senile dementia, or vascular dementia, microinfarct dementia, and obviously Lewy body dementia is a special type of that. So again, potential role of insulin in the pathogenesis of dementia, I think is quite an intricate side. Basically, it's showing the same thing that we know. And in type 2 diabetes, what happens to cognition? That a modest decline in cognition over time is possible even in people without dementia. But again, if we look at the more discipline, better treatment adherence, better treatment planning, more activity, there is, that decline can be arrested and kept to the minimum. And that doesn't have to be the case. So I think it's very important that the physician does not give an idea that when the diagnosis of diabetes is shared, that it's all doom and gloom from here on. But at the same time, should not be overly, should not understate the importance of discipline and exercise and good treatment adherence with goals which show that cognitive decline to be prevented or arrested. Memory, verbal memory, information processing speed, attention, executive function, all those things can be normal and carry on well, provided one is very careful with all the treatment protocols. And those slowly progressive processes can be age-related decline rather than early manifestations of dementia. Dementia only affects a subset, possibly added effect of Alzheimer's or severe cerebrovascular disease. So if those factors are prevented, and obviously one can't prevent the genetic aspect, but the cardiovascular aspects are prevented, diabetic glycemic control related aspects are prevented, and the positive aspects of exercise, good discipline, they are encouraged, then there is no reason that there has to be a progression. What are the predictors of cognitive impairment and dementia in older people with diabetes? Now, surviving participant of this Fremantle diabetes study, which must be very famous in the diabetic field, showed that of the 302 participants, 28 had dementia and 60 had cognitive impairment without dementia. Out of the 28, 16 with probable Alzheimer's. So the major independent longitudinal predictor of dementia were older age, which makes sense, but also diabetes duration. And why should depression be treated, which is often undetected? We saw that 45% of patients, it can be undetected, especially sort of chronic dysphoria or dysthymic disorder, which is slightly less than major depressive episode or major depressive disorder. But it also is important to recognize it and treat it with either therapy, cognitive behavioral therapy, or one of the modern specific serotonin SSRIs, specific serotonin reuptake inhibitors. So increase insulin sensitivity, index of insulin sensitivity following tricyclics antidepressants, but nowadays we hardly use them, but can be used in some adults. Decreased BMI, total fat mass, HB1AC, and improved self-care with, here it is said bupropion, but it's true for SSRIs and some of the medications like sertraline, fluoxetine, and to be honest, many antidepressants, and which are the sort of modern antidepressants. They can have a real good effect on improving insulin sensitivity and helping depression directly and diabetes control indirectly. This is a lovely mini-cog test, which is culture independent. So any culture, it can be given. Basically, 3 items are mentioned to the patient. It's actually given at the bottom. Step 1, ask patient to repeat 3 unrelated words. And apple, table, penny is an example. And remember them. Then ask patients to draw a clock face. So just a round, large circle, and put the numbers of the clock to look like a clock. And then set the time to 5 minutes to 3 o'clock. Ask patient to recall the first 3 words, apple, table, penny, and then those who can draw the clock and who show at least 2 items or 3 items are non-dementic. Those who cannot remember a single thing, and also the clock face is quite abnormal, clearly there is something wrong and they need more assessment for quantifying the dementic process. Now, what medication to, suppose if you have a patient with diabetes and who also is taking antipsychotics or who develops psychosis, then it's important to know that his medication, the antipsychotic, may need to be changed to try and give him maybe something little old-fashioned like haloperidol with preventive medication for Parkinsonic side effects, or even though quetiapine, risperidone is shown as moderate, quetiapine has slightly less tendency to interfere with diabetes as compared to risperidone. Risperidone is certainly can be quite toxic. Phenothiazines can be, like chlorpromazine, can be quite toxic, but also it can cause extreme sedation and hypotension. So clozapine and olanzapine can certainly have a very bad effect. So I would go with something like haloperidol, trifluperazine, or amisulpiride. And similar, aripiprazole is wonderful. So, oh yes, amisulpiride and aripiprazole are mentioned in the slide. They are the minimal potential to cause risk of diabetes. And what happens that psychotropic drugs like clozapine, quetiapine, risperidone, they can cause metabolic syndrome. So syndrome antipsychotics, which are the clozapine, quetiapine, risperidone, and olanzapine, of course. Tricyclic antidepressant, the old-fashioned, valproic acid and lithium, they all can lead to this. The metabolic changes are basically liver enzyme changes, as well as the lipid profile getting really disturbed, as well as the blood sugar tolerance getting extremely disturbed, and people can develop diabetes. So one has to keep the protocol of, if someone is on those medications, they have to have in UK we do the blood tests every 3 months. Canadian guidelines Dr. Suhas showed. So it can be, depending on the condition and the amount of medication, it can be from every month to 3 months to, sometimes if it's a very small dose, then it can be 6 months as well. Especially in child adolescent psychiatry, we often use very small doses, so it can be less rigorous than in adults. Now, this is important to know that cytochrome interactions can affect the induction of liver enzymes as well as the absorption of other medication that the patient may be on. So fluoxetine and fluoxamine, they can inhibit and affect the level of the antidiabetics. And even sertraline and the previous two can have an impact on glimepiride. Now, Dr. Suhas will obviously, and physicians using the antidiabetics will be more familiar with the antidiabetics. I'm more familiar with the antidepressants and antipsychotics. MAVO inhibitors, we in child adolescent psychiatry, we hardly ever use this. In adult psychiatry, we do use it often for as a second or third line medication for resistant depression or obsessive compulsive disorder, which is not getting better with first line or second line medications. They need specific dietary restrictions, because otherwise you can have very dangerous, serious reaction with tryptophan. And they can lead to hypoglycemia or orthostasis and other. They interact also very widely with any other medication. So the tendency is not to use MAO inhibitors. And tricyclic antidepressants, which are very old, like imipramine, amitriptyline, dothiapine, doxepin, all those we hardly ever use. I haven't used them for 15 years at least. Weight gain, increased glucose, cardiac conduction delay. So all those are out of fashion now. Most people will use SSRIs, and they are usually fine. So sertraline, fluoxetine, fluoxamine, paroxetine in adults sometimes can be useful, but it's often banned in some countries. Then there are many other antidepressants that keep coming in the market, duloxetine, which can be used. Now, it's very important to diagnose depression in diabetes mellitus, but the criteria to diagnose depression in general in the psychiatric literature are there, but there are specific criteria for using in physical illness, chronic, any physical illness actually, diabetes being one, but I can think of if you have a patient with asthma, a patient with chronic rheumatoid arthritis, patient with chronic lingering sort of serious illnesses like lupus or many other chronic illnesses really, then you can certainly, definitely, I would recommend that you look for depression and anxiety by using very, very simple tests, which we'll see in a minute. If you use inclusive approach, then there is a problem of overdiagnosing. So just asking one sentence, do you experience low mood, can lead to too many. If you use very exclusive approach and just include patients who give answer to 3 out of 4 questions as yes, then you are underdiagnosing and keeping many ill patients out. Etiological approach is not very useful because often you don't really know what is causing the depression. So substitute approach is the Endicott's criteria, or there are other criteria called Cavana criteria. Now, right, I think I don't have the slide here, but basically what happens is that in people with physical illness, you look for whether the patient has appetite loss or weight loss, sleep disturbance, fatigue and loss of energy, agitation, or psychomotor retardation as the physical side of depression. So all these physical things that I mentioned are the physical manifestations of depression in a depressed person. But think in terms of what are the concomitants, what are the substitutes if you think of the mind. So on the physical side, you have appetite, weight loss. On the psychological side, you got tearfulness and depressed appearance. Sleep disturbance on one side, social withdrawal on the psychological side. Decreased talkativeness, brooding, self-pity, pessimism, lack of reaction, lack of reactivity. And this is what we psychiatrists automatically do when we do mental state examination. We are looking for both the physical manifestation of depression as well as the psychological manifestation. So in Endicott's criteria, these physical things are substituted by the psychological thing. In Kavanagh's exclusive criteria, rather than substitute, he excludes the physical things completely and only asks for the psychological things. Difficulty in concentration, guilt about having done something wrong, low self-esteem, and thoughts of suicide or death. Those are the Kavanagh criteria. I think if you Google, you may find out the exact criteria, and certainly it's very, very helpful to keep one of those simple questionnaires in your practice, in print plenty of copies or actually do it online with the patient. And then if it's done as a routine screening of every new patient, you just know that 5-10 minutes you need to spend on managing the psychiatric side. Anything more than that, it may be useful to refer to a counselor or psychologist who is experienced in these matters, or even a psychiatrist for prescribing. So achieving best practice in dementia, we are talking about mainly, and we are talking about early stage dementia, going on to the advanced stage on one axis. Step one will be in dementia care setting, if in the old age psychiatrist dealing with it, should be aware of the symptoms and active screening of diabetes. The diabetic care setting, they should be aware of the screening for cognitive decline and dementia. They can do the mini mental state examination, which is a bit longer, but mini cog is really wonderful. That's absolutely easy, as we saw. And stage 2 on the dementia care setting, symptom alleviation and complication screen, consult with a diabetes team to start diabetic treatment to alleviate the physical symptoms. Screen for complications, eye, feet, kidney, cardiovascular disease. Repeat biannually, so every 6 months. The stage 2 on the diabetic care setting, ensure self-management deficits are addressed, eliminate diabetic symptoms, and concurrent infection that may exacerbate confusional state. Stage 3 is the risk minimization, because you can't cure, or so it's like harm minimization, risk minimization, prevent complications that will reduce quality of life, eye and feet, reduce falls and hypoglycemic risk by reviewing the medications, promote good nutrition. And if you are on the diabetic side, avoid overly intensive management use therapies that reduce risk of hypoglycemia. And obviously in advanced dementia, you have to do all that you can to just try and improve the quality of life and think in terms of minimizing the risk of getting lost and helping with basic functions. It's interesting that as long as as early as 1879, Dr. Sir Henry Maudsley recognized that diabetes is a disease which often shows itself in families in which insanity prevails, in the Pathology of Mind, published in one of the oldest psychiatry books. And so we are not inventing things often, we are discovering things. They have been there for a long, long time. Thank you very much. Thank you.
Thanks a lot, sir, for having very, ending it with the very informative and kind of, information what you have shared with us. Sir, before, signing off from the presentation and from this session, I would like to thank both dignitaries for giving us very informative and elaborative talk and highlighting the importance of spectrum of challenges routinely faced by clinicians. So collaboration with multiple specialty segment will be a critical step in achieving better patient outcome as far as type 2 diabetes and its associated comorbidities are concerned. So once again, thank you very much for participation in this event. Thank you, sir. Thank you, Dr. Erande, sir, and Dr. Banhatti, sir, both. Thanks a lot again. We'll wind up the session now. Thank you, sir. Thanks a lot.
Thank you. Thank you, Rajeev.
Thank you.
Thank you, Manisha. Thank you, all the participants.
Very welcome. Thank you.
Thank you.
Thanks very much, Manisha, for all your support.
Thank you, sir.
Thanks, Rajeev.
Okay. Bye.
Much.
Thank you, sir. So can I end the meeting with your permission? So I am ending this meeting now. Thank you.
Epilepsy. We'll talk of some movement disorders that looks like epilepsy and some epilepsy that look like movement disorders. But again, there's a lot of overlap. And at some places where we don't know, it's MD or epilepsy. And some places like in Wilson's disease, you have clear dystonia, you have clear seizures. So we know that there are two phenomena in the same patient. So I'll talk in these lines. But of course, there's overlap, as I told you. Movement disorders will look like epilepsy only when they're episodic. So once movement disorder starts being episodic, when hyperkinetic starts being episodic, they may mimic epilepsy. Now I'll show you 2 or 3 videos of this movement on one side of face. This is very clearly for even a first-year neurologist, this is hemifacial spasm, right? And for students, I would say that one should, when we see a hemifacial spasm, one should look the eyebrow. In true hemifacial spasm, the eyebrow will go up because facial nerve is supplying the frontalis also. So there is here, if there's contraction of overactive frontalis, that is true hemifacial spasm. And this girl is psychogenic hemifacial spasm, where eyebrow is going down, what we call as other Babinski sign. So this was HFS, the first was HFS, second was psychogenic. Now third, the phenomenon looks like HFS again. One may argue that he has more of clonic movement, but we all know that HFS can be divided into tonic and clonic. So it looks like HFS again. But when you hear his voice, I'm asking that, what is your name? He can't speak properly. I asked that how many fingers I'm showing. He can't speak properly. He showed 2 fingers. So this patient might look like HFS, but it is much beyond that, and his EEG was abnormal. So his epilepsy partially is continuous. So through these 2 videos, I wanted to show that EPC can easily be confused with, easily be mimicked by HFS or vice versa. So this was easy for me because there was speech problem, but one case was published by Alberto Espe group. And in that case, this is the case. I'll show you 10 seconds only. In that case, left side of face was involved, and he had this spasm. Again, one can easily tell that this is hemifacial spasm. But when he went for the EEG was abnormal and corresponding abnormality was there. When he went for bold sequence, it was abnormal again. So EEG showed right inferior frontal epileptiform discharge. EEG fMRI shows abnormality. So this was not HFS. This was not peripheral. This was more of central. And that was quite amazing because a classical case of HFS without any signs and symptoms, EEG was abnormal. And his contention was that many cases of HFS, at least few cases of HFS, they're epilepsy, they're focal epilepsy, and they respond to CBZ, carbenzapine, because epilepsy can respond to CBZ as well as hemifacial spasm. Moving on, some focal dystonia. If dystonia is tonic, again, if dystonia is like that, it's easy for us. But if in some focal dystonia, there is some jerky movement, what we call as dystonic tremor, or some jerks are there. Like this patient, the EEG was normal, and he is a case of focal dystonia. He has for a long time. We gave Botox. He has responded to it, but it's very easy to label this as a focal, simple focal motor seizures. Now, PLMS. This is a peculiar phenomena, not very common of sleep, but this may mimic focal seizures. Periodic episodes, more than 15 times an hour, it is quite frequent. Repetitive, highly stereotyped. It will keep on repeating the same way. Maybe associated with brief arousal, and sometimes with RLS. It can be seen with RBD, REM sleep behavior disorder, renal failure, PD, intake of antidepressant, and others. So this is a movement disorder, a sleep disorder. You see, in a way, it will come in right side. You can see that there's extension of grade 2, extension of ankle. And that is PLMS. Again, this can be confused by, or this can mimic focal epilepsy, clinically at least. So this was easy because this was distal, only grade 2 was involved. There was some extension of grade 2, which is classical PLMS. But in some case of PLMS, what they reported in neurology about 4 years back, rather than toe movement, rather than ankle movement, the movement was over whole right leg, whole leg. And they named it complex PLMS because EEG was normal. And the patient has RVD also. So moving on, status dystonicus. Some cases of status dystonicus, they have clonic component, and they can mimic status epilepticus. This patient is a case of Wilson's disease, came in bad shape. You can see that whole body is twisted. This is almost fixed right now, but in a way, many times he used to throw jerky movements. So this is status dystonicus, which can be life-threatening, which need urgent treatment. But such cases can be confused with status epilepticus. Generally, this happens in pre-existing conditions, so that gives way. The pre-existing conditions like NBIA or neurodegeneration with brain iron accumulation, Wilson's disease, cerebral palsy. On the top of that, if there is some inciting thing, then it can happen. This was status dystonicus. Ocular crisis. Again, this is a form of dystonia. This unusual movement, unusual dystonia, paroxysmal, conjugate, tonic gaze deviation. It goes generally up. Look at this patient of ocular crisis. In some cases, there can be spasm of eyelid also, which he has. No loss of consciousness. Now, almost similar phenomenon can happen with seizure also, as you see in this patient. This patient EEG was abnormal. And you can see the difference is that in first case, there was tonic deviation. In second case, when you see, there's clonic component. Moving on, hemiballismus hemichorea syndrome. So this is a movement disorders, but phenomenon can easily be mistaken as epilepsy. In this case, things were easy. The reason is that he had a stroke earlier, about 2 months back, and gradually it evolved into hemiballismus hemichorea syndrome. So it was progressive with history of stroke, things were easy. But this lady came in ICU with acute onset, right-sided movement, which can mimic focal seizure again, but her EEG was normal. and the sugar was very high. So she was in non-ketotic hyperglycemia and responded very well to sugar management. In such case, you can see that CT scan or MRI may show asymmetrical, many times asymmetrical basal ganglia hyperintensity. Generally, this is seen in elderly age, but there is no age bar. This patient, I got the video from Dr. Neeraj Kumar of Rishikesh, and again hyperglycemia. And this patient has left-sided jerky movement, which is coriform movement. Patient responded to sugar management, and EEG was normal. So these cases in ICU, when we see an elderly lady or elderly people in ICU with focal seizure, the first thing comes into my mind, focal movement, first thing comes into mind is hyperglycemia. But similar thing can be seen in true seizure also. This is not hyperglycemia. This is a case of head injury, previous head injury, right frontoparietal glycotic area. And you can see the abnormal movements. So this is classical seizure. At that time, seizure was going on, but this can be easily taken as chorea or sometimes rest tremor, because when you see closely, there's some component of rest tremor. But this was acute onset. EEG was abnormal, responded to anti-epileptic, so this was seizure. In corticobasal degeneration, which is one form of Parkinsonism, many times we find myoclonus which is quite prominent, along with dystonia. That gives the impression of focal seizures, focal motor seizures. But again, history, progression, and other signs of bradykinesia that helps us to define that this is CBGD and not focal seizures. Some rare tremor syndromes, if episodic, they may look like seizures, like limb shaking TIA, hereditary geniospasm of chin tremor, spasmus nutans, shuddering attack, they are benign form, and bobblehead doll syndrome in case of third ventricular cyst or any third ventricular lesion like this patient has. So bobblehead syndrome, in some kids, it comes in episodes, and then it can be taken as epilepsy or can be taken as seizures. Moving on to another type of movement disorders. This is the important paradigm, paroxysmal dyskinesia. That is a true overlap between movement disorder and epilepsy, because they are channelopathy. They respond to anti-epileptics. And in one case, you can have more than one phenomenon. That includes movement disorders, that includes seizures. And the types are PKD, that is kinesiogenic, PNKD, that's non-kinesiogenic, PED, that's exercise-induced. But rather than going into detail, I'll come from genetics, only one slide. That in case of SLC2A mutation, that is solute carrier 2A mutation, there will be paroxysmal exercise-induced PED and GLUT1 deficiency. In PRT mutation, there is PKD. In PNKD mutation, that's as name implies, PNKD. But some other mutations, like potassium calcium channel activity channel, you will have more than one. That is, apart from dyskinesia, dystonia, you will have epilepsy also. In case of sodium voltage gated channel, you can have PKD plus epilepsy also. In case of PDC deficiency, you can have PED plus epilepsy also. So some channels, some channelopathy, some mutation, they lead to both paroxysmal dyskinesia, which is non-epileptic, as well as epilepsy. Out of them, I'll show one case of GLUT1 deficiency. This patient is about 12 right now, has history of seizures right from early childhood, 4 years or so. But now seizures are controlled. He has come with this episodes of dyskinesia. So he walks normally, and suddenly he starts walking like this, where he throws his body on both sides. This lasts for a few minutes time, 3-4 minutes time, 5 minutes time, and then he gets better. So this boy has episodes of these dyskinesias, and when we went into history, he had seizures. CSF glucose was low, and genetic test confirmed that it was GLUT1 deficiency. This patient, the genetic test is still awaited, but this patient, again, you see that while sitting, he's okay. When he starts walking, after a few steps, he has this abnormal posturing. Initially looked like functional, but he has abnormal posturing. And gradually you can see that, look at his eyes. Gradually he goes into some form of trance where he is not knowing that what's happening. So he has some dyskinesia followed by this seizure-like episode. And that is almost all the time movement induced. Okay, some other movement disorders that may mimic seizures, the rare movement disorder. This is from my fellowship time, video courtesy Dr. Mandar. She's a case of DYT11, myoclonus dystonia syndrome, with the jerky movement myoclonus. Myoclonus is a phenomenon which epilepsy people feel that this is mine. Movement disorder people feel that this is mine. So she has DYT11, EEG normal. And ADC5 mutation that has been described only a few years back. They can have this myoclonus, they can have dyskinesia, but more importantly, in the night time, there can be sudden exacerbation, and that may lead to understanding that this may be nocturnal epilepsy. Moving on, a few slides regarding epilepsy that looks like movement disorders, where they are confirmed cortical origin, but they look like movement disorders from phenomenon point of view. Any focal seizure, which has only motor onset, can be mistaken as dystonia or focal myoclonus. Automatism can be mistaken as orofacial dyskinesia, which in our field we see quite often after medications, after antipsychotics. Focal tonic seizures can be interpreted as dystonia. Focal clonic seizures may be interpreted as tremor. Epilepsy partialis continua we just talked about. So there's nothing much to. In nocturnal frontal lobe epilepsy, there are a lot of sleep phenomenon which are non-epileptic in movement disorder field or sleep field, and that can be confused with nocturnal frontal lobe epilepsy. NFL is NREM sleep stage, but in movement disorders, majority of in a REM sleep stage. Like RBD is very common in Parkinsonism. RBD is one of the strong predictor of development of Parkinson's disease in later life. That I think one of the strongest predictor. RBD means REM sleep behavior disorder, that was enacting your dream. One big phenomenon, head drop. Head drop, you are fine, and suddenly head drops down. That can be seen in both movement disorder world as well as epilepsy world. In movement disorders, some patient with tics, they have head drops. Stereotypy like head banging can be seen. In chorea acanthocytosis, head drop can be presenting feature, and of course in paroxysmal dyskinesia. On the other hand, in epilepsy, myoclonic aesthetic epilepsy, you can have head drops. PME, any form of PME, you can have head drops and infantile spasm. SSP is almost unknown in Western world. And even student of first year, student of neurology, when we see this slow myoclonus, suddenly slow myoclonus, they will say that this is SSP, and this EEG correlate for that. But for uninitiated, this can look like myoclonus, this can look like chorea sometimes. So this is easy for us because we see quite often. But this patient, the second patient, he is a case of SSP. His myoclonus is different. While walking, suddenly his myoclonus leg is more affected. And you can see he stops, he walks with small steps, giving the impression of freezing of gait, but actually it's myoclonus coming to the legs. Suddenly he stops, this freezing of gait, his sensorium is maintained. So this is a case of SSP where myoclonus was more on the legs rather than hands. SSP is great mimicker, and some case of SSP, they come with various other movement disorders like dystonia. You see this patient have more of dystonia. I'll show you quickly. Yeah, you can see that hand is going up. She had to hold the arm down. Finger is pointed. So SSP can mimic anything, any movement disorder, I would say. Some rare epilepsy syndrome with movement disorders, which may have movement disorders, Rasmussen encephalitis, they can present hemichorea, Parkinsonism, and corticobasal-like phenomenon. Dravet syndrome, hemimyoclonus, enterocolis they may have, and some case of Dravet syndrome, they have Parkinsonism that respond to levodopa, quite surprisingly respond to levodopa. And we know that progressive myoclonic epilepsy, as the name implies, it has myoclonus, and a lot of them have ataxia. Coming to a couple of slides regarding autoimmune encephalopathy, where you have epilepsy as well as movement disorders. This is mild perioral movement, where there's encephalopathy, seizures with this perioral movement, and anti-NMDA, the NMDA receptor antibody was positive. This is mild, but sometimes it may not be mild. Look at this young lady, and it was so violent that she bit her tongue, bit her lips. It's quite gruesome to see that. And for students, any patient, any case having encephalopathy, having seizures, having some movement disorders, look for autoimmune or anti-NMDA encephalitis. And this faciobrachial dystonic seizures in anti-LG1, this is quite classical. There's still debate, there's cortical origin, subcortical origin, but this is classical faciobrachial dystonic seizures in anti-LG1. VGKC antibody. So I'll finish with the last slide that whenever a case of seizure plus movement disorder come, we talked about seizure looking like movement disorders. We talked about movement disorder looking like seizures. We talked about in some patient, we don't know whether seizure or not, but it is classically seizures with movement disorders. Depending upon the clinical features, these things should be seen. NMDA receptor antibody, NBIA if it is chronic, young, Wilson disease, gluten deficiency if it is episodic, cerebral palsy if it is long-standing, Rasmussen encephalitis if it's unilateral and more of myoclonus, ADCY5 with myoclonus or dyskinesia, more in the night time. SSP, we talked about that it can look like any movement disorders. Rett syndrome, if it is stereotypy. Dravet syndrome, again myoclonus. And elderly with seizure, with myoclonic jerk, and rapid cognitive decline, CJ disease. So to answer again, can a movement disorders be mistaken as epilepsy and vice versa? The answer is yes. And thank you very much.
Thank you, Dr. Hrishikesh Kumar. That was lovely, beautiful talk. Very intriguing, very interesting, and the videos were lovely. Do we have questions for Dr. Hrishikesh Kumar? Any questions for Dr. Hrishikesh?
Sir, in chat box, there is no questions. Only thing they have appreciated is well, and they have asking for more case presentation on hemifacial cases. So
Very good. Very good. I'm sure he will oblige. I have one question for Dr. Hrishikesh.
Yes, sir.
There are some reports of anticonvulsants, those patients who are on anti-epileptic drugs. The anti-epileptics itself inducing dyskinetic movements. Your experience on it?
Yeah, reports are there, sir. For I would say for myoclonus, I'm convinced because some medications like CBJ, phenytoin, that can produce myoclonus. Even dyskinesias, very rare case reports are there, but I would say that I have not seen any case of anticonvulsant induced dyskinesia or dystonia. Okay, myoclonus I'm okay, but dyskinesia, dystonia, it's so rare that I have not seen it.
Phenytoin has been reported many times, and valproate also occasionally. But actually, potentially all the drugs, even levetiracetam, they have reported dystonia, dyskinesia, choreothetoid with anticonvulsants. So I was just wondering, it can complete the overlap between movement disorder and epilepsy.
Yeah, at one point in time, we have to understand the mechanism which we don't understand right now, because same medication is touted as causing abnormal movements, and some anti-epileptic are used for the abnormal movement, like zonisamide is being used for levodopa-induced dyskinesias.
Correct.
So we have to go down to the molecular level and see that how this work in different patients.
Perhaps our knowledge is still limited in this field.
And one question regarding hemifacial spasm, I would say that is very interesting, because hemifacial spasm is not all the time facial nerve hyperactivity. Some tics can present with as hemifacial spasm. So various phenomenon can present with HFS.
Dr. Singhal, sir, any questions?
Just a comment, if I may.
Yeah, please.
Valproate has been associated with Parkinsonian features in a small sample size reported in the past.
That's true. That's well known.
Yeah, that's well, yes.
With the permission, I just wanted to add one thing. When Hrishikesh told an interesting case of oculogyric crisis, I just wanted to share one point that in oculogyric crisis, when the eyeballs uprolls, there won't be any wrinkling on the forehead. Whereas in malingering, there will be a wrinkles on the forehead. Whenever you can't uproll your eyes without the forehead. So this point, because oculogyric crisis happens in the upper in the supranuclear pathway of the eye. So this would differentiate between a pseudo-oculogyric crisis and an oculogyric crisis, which is the pseudo-oculogyric crisis is very common in any psychiatric situation, because most of them, they want a shot. They are addicted to Phenergon. They want a shot of Phenergon. So they will come and show you, then they immediately get a shot of Phenergon and then walk away. So that's, I just wanted to add that point. So because I've been associated with the mental hospital.
Any other questions from the audience for Dr. Hrishikesh?
No, sir.
So Dr. Hrishikesh, that was wonderful. Thank you so much. Over to Dr. Singhal, please. Dr. Singhal, sir. Okay, I think he is offline.
So we move on to the next topic, that is on dementia mimicking seizures, Indian and global perspective, challenges in the diagnosis in the elderly. Is it dementia, delirium, drug, or seizure in this? None other than Professor Dr. Lakshminarayan Narasimhan. He is a phenomena himself. He's heading the Institute of Neurology, Madras Medical College, Chennai. He's a PALF graduate international advisor of AN. He's a founder member of the South Asian Cochrane Network and site coordinator of Chennai. He's a founder member of the advocacy wing in the Academy of Neurology. He's received the Palatusi Award from AN, prestigious A.B. Baker Presidential Award for Global Best Teacher in Neurology from the AN, Best Teacher Award in Neurology from Dr. MGR Medical University, Best Doctor Award from Tamil Nadu Government. He's a member of all the professional bodies. He's a liaison member of the WHO Neurological Policies. Gentlemen, Professor Dr. R. Lakshminarayan Narasimhan.
Yes, sir. Thank you so much for your generous introduction, sir. And what I'm going to do is take you to. Can you see my slide, sir? Is it
not yet? Now we can see.
You can see the slide.
Yeah.
Okay. It's essentially a panel discussion on challenges in the diagnosis of seizures in the elderly. So you always, is it dementia, delirium, drug, or the seizures? And more important, sometimes even TIA confuses you. In an elderly person, so I have experts with me, Dr. Nirmal Surya and Dr. Trinka. He is, during his talk, Professor Trinka told a lot of important things on post-stroke seizures. So even not only post-stroke seizures, sometimes limb shaking TIA, which Rishikesh showed, can also be a mimicker to produce a challenge in the diagnosis of seizures in the elderly. So let me take up a case scenario and then take forward with our panelists. A 56-year-old man with no medical comorbidities who used to work as an electrician was initially brought by his family to Psychiatri hospital, walk-in clinic seeking help for memory loss for 10 years. During this time, the patient's family endorsed mood swings, social isolation, unsteady gait, and word-finding difficulties. Several months after the symptom onset, the patient's family noticed that his memory loss became more prominent and he was unable to follow past event timelines, for instance, arguing that long ago events have happened only days prior. The patient also forgot the names of close relatives, maintained poor sleep, less than 3 hours per night, and altered his normal daily routines. A point which is worth remembering is that the sleep rhythm gets inversed in dementia, and this sleep deprivation is also pretty common. As you all know, that seizures is a very common, one of the commonest trigger is the sleep deprivation. So it's not very rare to see seizure happening in this setting. A family also endorsed increased agitation, anxiety. Patient's functional skill began to gradually decline and he lost all skills required to do his job, which ultimately resulting in his being laid off. The patient's family reported that he lost his way home on 2 occasions and was untimely brought home after one day by strangers both times. Finally, the family reported one incident approximately 5 years prior to the current presentation. The incident happened during a family gathering when the patient lost consciousness for a few minutes. The patient was immediately taken to a neurologist, and MRI and EEG were performed, and the patient's first being examined by a neurologist. And a complete blood count, urea, electrolyte, liver function tests were all within normal limits. Patient had normal levels of B12, folate, and negative for HIV, and inflammatory markers were within normal limits. Patient's family refused for a CSF analysis. EEG showed persistent left-sided spike and wave activity over the temporal lobe region and with an amplitude of 50 to 80 microvolts, suggesting there was a suggestion that there is some left temporal epileptiform discharges. A head MRI showed bright T2 fluid attenuated flare focus within the white matter in both cerebral hemispheres surrounding the ventricle. You can see that there is a few here and there was a couple of there, and most of them are surrounding the ventricular system, but notably in the frontal and occipital horns, with no corresponding areas of restricted diffusion on diffusion-weighted image sequences, likely represented white matter ischemic related changes. Widening of, you can see there is a lot of atrophy. There is sulcal space in the wide end and deepened gyri implicating cerebral hemispheres and temporal lobe degenerative changes. The patient was started on carbamazepine, but according to his family, his condition continued to progress. Medications including quetiapine, which was later added to the patient's regimen to his sleep problems, hallucinations, were not efficacious. A mental status examination revealed average grooming and hygiene, poor eye-to-eye contact, and psychomotor retardation. A calm, quiet demeanor, irrelevant yet coherent responses to questions, and blunted affect. The patient denied experiencing any hallucinations later as any perceptual abnormalities, and no overt delusions and obsessions were noted during the examination. Cognitive assessment, mini mental state revealed a score of MMSE. It's not zero because the patient they were not able to do a MMSE. They were unable to do serial 7s or 3s. Patient's medical history indicated significant iron deficiency anemia, which he had no recorded history of hypertension or diabetes or dyslipidemia or stroke, head trauma, or any other chronic illness. Was not on any regular medications. He was a smoker since 18 years. 2 years back, he quit and denied any alcohol consumption. Finally, the patient's family, childhood development history were unremarkable. Educated up to secondary school, did not complete education due to financial reasons. Completed professional electrician training and worked as an electrician for more than 20 years. Married, 4 children, physical examination, no further abnormalities. At 56 years, 10 years prior to his latest presentation, patient was diagnosed to have a seizure disorder. Accordingly, he was started on carbamazepine at that time, then donepezil 5 years later, when his memory loss started. He did not show any improvement in his symptoms and a marked exacerbation of his forgetfulness. He was assessed as in an outpatient clinic for our psychiatry facility and diagnosed with early onset dementia. After the initial assessment, he was subsequently started taking memantine and quetiapine for the symptomatic treatment of his insomnia. Carbamazepine was discontinued, giving no evidence for clinical seizures. 1 month after the initiation of his treatment, patient's family reported improvement in his sleep quality and agitation, but not on his cognitive function. Okay, a question to both the panelists. In your practice, how much of percentage of patients you see with dementia and combination of dementia and seizures? I would like to get this question crossed into. Is Professor Kinka there? Hello?
I just muted my microphone. Yes.
Please, sir.
So let's say,
in your practice, how much a combination of a dementia and seizures, how common you see, and can you share your experience?
Yeah, it's not uncommon, and I would say it's between 5 and 15%, somewhere in this order. It depends on where in the course of the disease you look at. And my personal impression, and there are also some papers, that those which have mild cognitive impairment or which have an early dementia, they have a faster decline in cognitive function. But that's my impression, and we try to get money for a research project to look in that in further detail. But it's around, let's say, between 5 and 15, average 10% in my group of patients.
And given a choice, which anti-epileptic drug you would like to choose in this setting? What is your choice?
In this setting, I would choose levetiracetam. This is drug of choice number 1 in the elderly. And if there are any behavioral problems, I would go for lamotrigine as a second one. I'm not sure whether I would take carbamazepine due to the cardiac effects and the high rate of
hyponatremia also.
Yes.
Hyponatremia also. Okay.
Yes.
So your preferred drug of choice would be levetiracetam and lamotrigine.
Yeah.
Okay. And I ask Professor Nirmal Surya.
Yeah. Good evening. Good evening.
What is what are your observations?
So I look at two ways. One is if there is a patient who comes with progressive dementia with an acute onset of neurological disorder like associated delirium, then the incidence of seizure increases very much. But on the other hand, as Professor Trinka has said, those patients who are chronically progressive dementia, there the incidence is 5 to 15%. And if you could put the slide, I have given one of the slide, if that can be shared, the association between dementia and epilepsy, a systemic review and meta-analysis, which was published a couple of years ago, and which is quite a beautiful paper.
You have sent me.
Yeah, I have sent to these people. So
I can stop sharing. They can share that. I can stop sharing.
That. So, which
you have that paper with you?
This is an epilepsia paper, association between dementia and epilepsy, a systemic review and meta-analysis.
We'll do one thing. We'll finish this discussion, and at the end of it, we'll share those papers. Is that okay, sir?
You have what Dr. Nirmal Surya has sent you. Ask your team to please project it.
So it is. It clearly says that dementia is among the top 15 conditions with most substantial increase in burden of disease in past decade, along with epilepsy, among the top 25 causes of years lived with disability worldwide. And sorry, yeah, no. The fourth one, the next, not this one. No, not this one. Yes, this one. So they have reviewed over 3043 citations with 64 full text, 19 articles are included, and the prevalence of dementia range from 8 to 17.5 per 100 person among person with epilepsy. So there is an increased incidence of even dementia in people who are epilepsy. And the pooled periodic prevalence of epilepsy among person with dementia was 5 per 100%. That is 95% confidential interval. In population-based setting, it was 4 per 100% in the clinical setting. So there was insufficient data to report a pooled overall incidence rate and only limited data on risk factor. So significance is significant gap in knowledge regarding the epidemiology of epilepsy in dementia and vice versa, and accurate estimation are needed to inform public health policy and prevention and to understand health resources need for this. So I think we really need to look into a further systematic study to really study how common is epilepsy in dementia, and on vice versa, those with chronic epilepsy, how many of them goes into the dementia. Thank you.
So, thank you, Professor Nirmal Surya. So the take-home message on this is one is Professor Organ Trinka said that it's a very good research topic for young neuroscientists. The incidence is somewhere between 5 to 15%, and the drugs of choice would be levetiracetam and lamotrigine in that order. And the Cochrane analysis, which Professor Nirmal Surya showed, that's still a lot of work to be done, and it's a wonderful area for research. So I just
want to add, Lakshmi, that lacosamide is coming as a wonderful drug, particularly as it is available both as IV and orally. And my experience in elderly with lacosamide is significantly good. So that may be considered as another alternative drug where you find that you may not be able to use levetiracetam as
kindly, I request all of you to kindly do the ECG before prescribing, because QT prolongation is pretty common with lacosamide. So, doing an ECG in an elderly person before starting on lacosamide with the word of caution. And lacosamide, lamotrigine, and levetiracetam are the three choices the panelists have narrowed down on an elderly demented epileptic. Thank you. Then we move on to, can you stop sharing the screen? I will want to share the next screen. Hello? Yeah. So we move on to the. Then this is another interesting, you know, the disease spells. When should we consider seizure or epilepsy in a patient with vertigo? The differences between vestibular epilepsy and vertiginous epilepsy, vestibular seizure, vestibulogenic epilepsy, all these different terms. And I just draw the attention, I want the opinion from, as you all know, epilepsy and vertigo again go hand together. Vertigo is a primary feature. It can be an aura. It can be an epileptic vertigo. It can be vestibulogenic, or vertigo can be a secondary feature following a brain injury or a structural one, or a complication of AED, or a coexisting inner ear disease. So with this is a pretty common combination. The epileptic patients come and tell that they feel dizzy, or if they have vertigo, or the other ways also. So I draw, what is the comments, Professor Ogentrinka?
First of all, the most common form is the one which is quite easy to detect. It's more related to dizziness, but in the sharpness of the distinction, many people feel it as vertigo. And then exploration can reveal whether it's a dose-related phenomenon, which you very often have with sodium channel blockers, but also with perampanel, which comes suddenly after intake, about 1 hour, and which is a severe feeling, very much vertiginous, and then it disappears. With the sodium channel blockers, you can also have nystagmoid eye phenomena as the peak of the dose phenomena. So that's, I think, the easy to identify. The secondary is the constant dizziness, which you have applied which you can find in the elderly patient. Again, it's a drug effect primarily in combination to the multifactorial vertigo. Then number 3 is what you have here on the upper part of your graph, vertiginous aura and epileptic vertigo. This is rare overall, and the clear-cut cases are coming down to a few very well described cases in the literature. So the vertiginous aura is something which the patient often describe, but when you ask them, is it really a turning up or lift feeling, or is it a rotatory phenomena, that's quite rare. If this is the case, it has a high localizing value towards the temporo-perisylvian insular region, and it's quite useful.
Insular cortex is one where.
Yes, insula and the superior temporal gyrus.
Okay.
Then the other part, which have you in the lower part, is also easy to distinguish. The coexistent inner ear disease, morbus Meniere, for example, it's very clear, and it's very clear picture. So the two seizure frequency does not interact with the Meniere frequency of attacks. Or if you have a vestibular neuritis, it's not different from people without epilepsy. And I think that's also make a clear analysis of the semiology of the vertigo. The more difficult thing is, and that's difficult to prove, vestibulogenic epilepsy, which is related to the vestibular stimulation of the vestibular apparatus causing epilepsy seizure, which is something I did not come across. It's obviously in European countries, very rare. The other thing which is more common is the brain injury or structural degeneration, and have a secondary vertigo, also related more to dizziness and not to the vertigo itself. So that would be my first glance of the very nice graph which you put forward.